Open Hartmann's procedure has been the standard surgical approach for managing perforated diverticulitis since the 1950s. However, primary anastomosis following sigmoid colectomy gained popularity since the early 2000s as an alternative option for these cases. This has been endorsed by the latest UK and US guidelines as a valid option for cases with perforated Henschel 3 and 4 diverticulitis. This is based on level 1 evidence of multiple meta-analysis and systematic reviews showing better short-term and long-term outcomes and stoma-free survival following primary anastomosis. Multiple systematic reviews compared laparoscopic and open approaches in emergency colorectal resections and found better short-term outcomes with laparoscopic approach, and this is presently being investigated by the LESIS2 trial. The Damascus trial showed that worldwide, 33% of emergency resections for perforated diverticulitis have been done with minimally invasive approach, and 31% of surgeons performed primary anastomosis with or without ileostomy after emergency sigmoid resection. However, our numbers do not reflect the global trend. This is a study we've recently published, which included over 1,000 patients with acute diverticulitis from 4 NHS hospitals, including Darlington and James Cook. Our study shows that out of 107 emergency resections, only 15% were done laparoscopically, and none of our patients had an anastomosis. I will present a short video of one of the cases who had an emergency laparoscopic Hartmann's for Henschel 4 diverticulitis at Darlington Memorial. She was a 76-year-old lady with rheumatoid arthritis and a BMI of 39. The patient was positioned in the Lloyd Davis position, then standard port placement for left-sided colonic resection, and then we start our procedure by doing a diagnostic laparoscopy to confirm the CT diagnosis and locate the perforation. Here we can see a large amount of feculent fluid in the abdomen, which is consistent with the CT diagnosis of perforated colon. We carefully mobilize the small bowel, suctioning all the contamination, taking some of the fluid for culture and sensitivity, trying to get the small bowel out of the pelvis to deliver the sigmoid colon and find the perforation site. Here we see the perforation in the mid-sigmoid colon. Then we are now ready to start our colonic mobilization. We start as we do in elective cases with medial mobilization, trying to identify the correct plane carefully. Find the left ureter, which we can see here. Preserve the ureter and gonadals. Continue medial mobilization. Then we divide the mesocolon. In this case, we elected to do high ligation because there was a CT suspicion of an underlying colonic mass, suspicion of a cancer. This doesn't have to be done in every case, unless there is a CT or intraoperative suspicion of underlying cancer. Lateral mobilization as high as possible. Here we can see the Toll's fascia. We ensure good mobility of the proximal colon after division. Once we choose a healthy area of the proximal colon away from the disease, we divide the mesocolon at that level. Here we are dissecting the marginal vessels and controlling them with hemolocks to ensure good hemostasis. And then the colon is divided using a stapler. After that, we dissect the TME plane to reach a healthy rectum, and then the rectum is divided using a stapler, and the specimen will be completely free. The histology of this surgical specimen didn't show any evidence of dysplasia or malignancy. However, out of our 107 cases, 16% had concomitant malignancy with diverticulitis. Here we are checking the mobility of the colon, which reaches the abdominal wall without any tension. Specimen was extracted through a Phanestoid incision. Another significant advantage of laparoscopy is having a smaller transverse incision, which makes the postoperative recovery better. Less risk of incisional hernia and scar tissue, which will make the potential reversal of Hartmann relatively easier. Then we do a thorough washout and place the drains. An incision is closed and the colostomy is made. The total operative time in this case was 140 minutes, which is relatively longer than an average open Hartmann's procedure. The patient stayed in hospital for 7 days. She made a very good recovery and she did not return to the hospital since the discharge. In conclusion, there are multiple advantages of laparoscopic approach over open. It should be considered in almost every case unless there is a contraindication or lack of resources. Primary anastomosis is a valid option which should be considered carefully in selected patients. Thank you.